Cerebral venous and sinus thrombosis. Cerebral venous and dural sinus thrombosis are uncommon etiologies of stroke. The pathologic thrombosis of venous outflow leads to the disruption of cerebral metabolism, breakdown of the blood-brain barrier, and impairment of cerebral fluid absorption, resulting in cerebral edema, venous infarction, and hemorrhage. Many conditions and risk factors are associated with cerebral venous thrombosis. The most common acquired conditions include pregnancy, use of oral contraceptives, and malignancy. Many prothrombotic genetic mutations are also associated with CVT, such as factor V Leiden and antithrombin deficiency. In addition, systemic inflammatory diseases, local infection, and trauma have been linked to CVT. The clinical presentation of CVT can be highly variable. Headaches, seizures, focal deficits, and encephalopathy are common presentations. The key to making the diagnosis is to have a high level of suspicion. Here we present our proposed algorithm for CVT based on American Heart Association and American Stroke Association guidelines. In patients with suspected CVT, we recommend emergent neuroimaging with MRI and MRV, or CT and CTV. Both MR and CT techniques are highly sensitive for diagnosis of CVT. Negative imaging should prompt consideration for an alternative diagnosis, or, in rare cases, a conventional diagnostic angiogram. The primary treatment of CVT is anticoagulation, typically with subcutaneous low molecular weight heparin or IV heparin. It should be noted that the presence of intracranial hemorrhage is not a contraindication to anticoagulation. Attention should also be given to treatment of seizures and intracranial hypertension, as well as the underlying cause of CVT, if known. Patients who are stabilized can be transitioned to oral anticoagulation, typically for a duration of 3 to 12 months, depending on the etiology of CVT. If the patient declines, repeated imaging is recommended. For patients with significant mass effect or hemorrhage, decompressive hemicraniectomy can be considered if more conservative treatments for elevated intracranial pressure have failed. For patients without mass effect, but with ongoing problems with venous outflow, endovascular thrombectomy could be considered. Many endovascular techniques have been reported, including the use of a stent retriever, an angiojet catheter, balloon angioplasty, venous stenting, and local infusion of thrombolytic agents. A recent randomized trial published in 2020, the TO-ACT trial, failed to demonstrate the benefit of endovascular techniques when compared to anticoagulation alone. This trial had a relatively small sample size and may not have detected a modest endovascular treatment effect. The prognosis of CVT can be variable. Approximately 5% die during the acute phase. Factors affecting prognosis include premorbid conditions, presenting mental status, and presence of intracranial hemorrhage. In addition, CNS infection, malignancy, male gender, and thrombosis involving the deep venous sinus system are associated with poor prognosis. Thank you very much. We hope you have found this helpful.